Thank you very much. Thank you very much for the invitation to come to this meeting. It's been fascinating. I fear that I'm flying the flag for surgery in a very endovascular session, so I'll do my best. And the topic I was given, or the title was this, was that popliteal-pedal bypass is more durable and a better option than endovascular treatment of 𝗙𝗏𝗏𝗏 disease. And that's a very generalizable title, and I probably should come to the conclusion first before I go through the talk that in some patients, yes, and I hope that will make sense as I move through the talk. I think certainly since I've been doing vascular surgery, the landscape has changed somewhat about the patients that we're dealing with. We are, well, I'm not quite sure where we are in the diabetes epidemic. It feels like we're in the middle of it, but I'm concerned that we're just at the beginning of it. We're seeing increasing numbers of patients who have got end-stage renal failure as a consequence, and certainly our ward is about 80 to 85% full of patients who've got feet like this. And because of the diabetes and end-stage renal failure, we're seeing a lot more patients who have very severe 𝗙𝗏𝗏𝗏 disease, and that has with it the challenges that we've already been talking about. My title was popliteal-pedal, and so that's very specific in as much as that when we talk about pedal, I think we're talking very much about below the ankle or at the ankle, probably more so below the ankle. And I think what we have within our MDTs is not so much the joust, but a discussion around how best to treat these. Is that surgery, or is that from an endovascular point of view? And I still am not sure there's a right or a wrong answer. And the second part of my conclusion is that it really is, again, as we talked about in the aortic session, a very patient-specific decision. So what do we consider around surgical bypass? Fitness for surgery. Are these patients have usually got multiple comorbidities, not just diabetes and renal, but significant cardiac histories in a number of these patients. We are very much in surgical terms looking at the distal target vessel and whether that is going to accept or allow a bypass to run. We want a conduit vein, definitely, more than 3 millimeters in diameter. And often these patients are poorly mobile, their skin quality might be poor in and around the lower part of the leg, they commonly have significant edema, and their ulceration might be impacting upon where you want to make your incisions. I won't touch too much upon the endovascular things that we consider because they've been well discussed in the last few talks. But certainly site and burden of the atherosclerosis is a key component that we discuss. Multiple vessel revascularizations we've touched upon already. Access issues can be challenging in diabetic patients who may have severely calcified vessels or degree of morbid obesity that creates access issues. And the benefit of endovascular revascularization is that ability to perform suprapopliteal interventions at the same time. Pop-pedal, by their name, is a relatively short bypass graft, and I think if you're thinking of taking a graft from the common femoral or proximal SFA down to a pedal, then that's probably not the right option to be undertaking. And certainly when we look at the literature, there are challenges. Throughout the whole of lower limb peripheral arterial disease, there is a marked heterogeneity around the patients that we are seeing. Their runoff is different, their atherosclerotic burden is different, their indication for intervention is different. We only have to look at the 𝗏 score to tell us the vast types or different types of patients that we may encounter that need revascularization or not. And certainly increasing calcium is a major problem, as we've seen already in a number of the talks. With endovascular intervention, the landscape is continually shifting. New devices are continually being brought to market. And so it's difficult really to get good, high-quality data on a lot of the techniques that are out there because technique evolution trumps long-term data. A lot of the data we have is retrospective, and that comes with it bias. We will only really probably put in our winners or case series that show good things rather than case series that show bad things. How do we define endpoints? We've seen a lot about patency here, but ultimately it's probably about the foot. Amputation-free survival, does that reflect what we're trying to do? I don't know. I don't have the answers for that. And certainly from the point of view of popliteal to pedal bypasses, it's very difficult to tease those cases out from a more heterogeneous group of lower limb surgical bypass. So we struggle to compare apples to apples in the literature. We've seen the endovascular results of infrapopliteal disease presented already. The results are pretty good. There's no doubt about it. This is a meta-analysis from the Netherlands that shows at, I think, 1 year, the patency rate and the freedom from reintervention and the amputation-free survival are actually pretty good. The data quality, though, is moderate or low. Surgical results, this is a meta-analysis of all popliteal to distal vein bypasses, splitting between pedal bypass and tibial bypass. And the pedal bypasses do as well as the pedal bypasses do as well as the tibial bypasses. But you can see out to 5 years, the results are actually pretty good for pedal bypasses, if you pick winners, I suspect. What about comparisons? There's not that much data. This is a large series out from Scandinavia, but about 10 years ago that this was published. And in general, when you compared endovascular versus surgical revascularization for infrapopliteal disease, there was no real difference between limb salvage survival, amputation-free survival, or freedom from further revascularizations. But in a subgroup of patients with definitive isolated infrapopliteal revascularization, it was suggested that angioplasty was better from the point of view of limb salvage and a lower, although there was increased need for further surgical revascularization. But again, I suspect that this is a very selected group of patients with bias, more likely to treat patients who are less fit, with probably less extensive foot ulceration with endovascular intervention. Again, this is a study that compares both bypass and endovascular intervention. You can see here that the populations are reasonably well matched, but again, it's probably an element of bias because you will be picking certain patients to go into certain groups. The target vessels, predominantly dorsalis pedis, posterior tibial or the plantars, venous conduit. But the results here on the right show the long-term outcomes. So from the point of view of wound healing, out at 6 months and out to 12 months, the endovascular group did better. But if you look at survival, primary patency and primary assisted patency, or amputation-free survival as well, surgical bypass did better. And again, I think that probably represents that this group were probably operating on patients who were fitter, performing endovascular revascularizations on patients who were not as fit, and perhaps undertaking interventions on people who had less foot ulceration in the endo group. And I think this is probably where, as we talked about this morning, probably where 𝗦𝘆 will help, and is it might be able to allow us to understand what sort of patients are being treated in these groups. So what do I think? Well, I've got no real pills of wisdom really to tell you exactly what you should be undertaking and when. I think it's quite easy to say, isn't it, right intervention, right patient and right time. I think surgical bypass has a role in these patients. Good vein, fit, good target vessel. We would, with heavy burden of disease within the infrapopliteal arteries, we would certainly be considering a popliteal to very distal or pedal bypass. But that's not me saying that everybody should get a surgical bypass and the results are more durable. So I think your MDT is important, and I think you need to consider everything about the patient to come up with the right decision. But unfortunately, I don't have all those answers. Thank you.